That was very nice, Raju. You took us from, how to take out polyps to when and if should we do a colonoscopy, and if so, how and with what tools. Fantastic. So we're going to open it up to questions. So please come up to the microphones, and I'll just start while we're waiting for people to come up. I guess the poll study to me was really interesting with cold versus hot EMR for larger polyps. And I wasn't at the session, so I don't know if they did a multivariate analysis, but very clearly, I don't know if we want to pull up the slide, but there was a huge difference, as you might expect, between use of clip closure, almost every patient with cold, because people were probably worried, there's actual bleeding there because you didn't use coagulation, so they're probably treating immediate bleeding rather than worrying about delayed bleeding, perhaps, which think a priori would be more common with coagulation. And then B, almost none of the cold snare patients had any kind of treatment of the periphery, whereas almost every patient with the hot EMR did, as you might expect. So I'm wondering if those two confounders actually explain the observed difference that, cold you clip, prevent bleeding, and hot you coagulate and you prevent recurrence. So I don't know if anybody else was there or asked a question at the session, but any thoughts?
I'll make a general comment first. Before we go and talk about cold EMR versus hot EMR, this is 2024. In 2024, we are still seeing high recurrence rate in double digits from experts. These are all experts who are doing the procedures. And that actually bothered me. And I actually reached out to Heiko Pohl and I asked him, Heiko, did you have a bunch of people who actually push your numbers to the double digit for hot EMR? And Heiko said, no, we looked at that data. Every center, when they looked at it, they had the same number. These are 20 millimeters or above. They're not 40 millimeters or above. And to have that type of recurrence rate for hot EMR, I don't know why. It would be interesting to see actually, a lot of times, you can learn a lot if somebody puts in the figures and says, images and say, hey, this is what we thought we resected. And in my view, it was a complete resection, but I'm surprised it came back as a recurrence. So that's one general comment. I'm still a little bit bothered by that. In terms of the cold EMR, we started with cold resection. I give a lot of marks to Cyrus for bringing the cold concept. The cold concept is good for small polyps, between 3 to 7, 8 millimeters, and beyond that, I really don't use cold. I just use hot. The thing is, we always worry about the complication of bleeding and everything else, right? So I wonder, I don't know the answer for this, but after seeing the cold EMR concepts come out, I changed my technique. So what I started doing is, for my EMR, hot EMR, I try to close my snare as if I'm actually cold cutting, right? But before I do the cold cut, I just apply very little current. That will give me, like a hot EMR, it's a clean cut, and I don't see any bleeding. With cold EMR, you do see bleeding, and you don't know whether you still have polyps left there, because it's very difficult to figure out what you have cut, what you have not cut. The other concept is that has actually come out recently from Michael Berg's group is you have to remove the muscularis mucosa completely. If you leave muscularis mucosa, they have shown that those patients developed recurrence. So there are so many different small things that people need to keep in mind. And I ask myself when I'm telling my fellows, your goal is to have a complete cut. That means cut into the submucosa, cut the margin so that you don't have anything, and you take a photograph to document that you see normal round pits around that margin. And then you should not have any recurrence.
Oh, Raman, yes, please.
Yeah, no, great presentations. And you sort of addressed a little bit of what I was about to ask, but I was just going to ask both of you in terms of, the options that you have now in terms of, sort of cold EMR, underwater EMR, and of course, sort of the traditional inject and hot snare. Are there certain situations where you are preferring going to underwater or a piecemeal cold snare in lieu of sort of traditional hot EMR? And if so, what are those cases?
Out of curiosity, in the group, before we answer, who uses cold EMR exclusively for large polyp resection? Just maybe raise hand. Nobody. Looks like it. And that's highlights, and I think it's probably personally, I think that is the way to go because, and based on what Dr. Raju mentioned, it's a very interesting study from Australian group, I think was recently published in GIE, looking at, well, I haven't said anything of importance probably. So it looks like not a lot of us are using cold EMR exclusively to remove large lesions, and probably because we're leaving some of the muscularis mucosa as Australian. I advise you to take a look at the study that came out in GIE fairly recently and was very interesting. We probably leave some behind. I think to answer, from my point of view, to answer Dr. Motasami's point, is whatever you feel most comfortable with. Whatever, as Dr. Raju pointed out, if you're meticulous about it and you did not leave visible adenoma tissue behind and you treated the margin, then you probably would be okay. Do you see the 2 digits recurrence rate in your experience, any one of you, if you do this meticulously?
So I want to share something. When I started my practice at Anderson, I said, okay, this is the protocol I'm going to follow, and that was published in GIE. I've not changed the protocol. I was a little bit, in 2016, when I was writing my manuscript, I was a little bit afraid to send my manuscript because my recurrence rate was 3.7%, and I said I must be outlier or I must be cooking my data, right? When everybody was saying 10%, 15%, even now 10%, 15%. And I looked at it in 2019, it still remains low. In 2019, it was about 20 millimeter polyps. So you can, but when I asked myself to come up with an explanation, I make sure that all my patients are done under general anesthesia. I think it gives you a stable field and it will actually allow you to do a better resection without having to deal with the movement that happens in these patients. Most of these patients who have large polyps are also obese and they breathe with their abdominal movement, and then you're trying to compensate. And you may not have the patience to look at it, whether you left any tissue. You say, hey, I've got most of the done, I'm going home. Regarding Raman's question, I use cold snare resection for small polyps, EMR hot for everything else. The only time I use underwater EMR is if I'm going in and I'm losing my scope position because the moment I distend the colon becomes longer and I slip back. In that case, I've done underwater EMR. The reason I've not done underwater EMR was I felt uncomfortable with my cut, whether I will end up with a perforation. That's my, inherent fear. And it doesn't really matter, what matters is complete cut using whatever technique.
Chuck,
Dr. Raju, do you think if you had the optical AI looking over your shoulder, that you could teach the AI where those skirt margins are? I know Dr. Binmuller, Dr. Bork, and many others have taught us to try and, like tattoo, use a little hot tip and mark out your margins. And I wonder if you either teach your fellows that, or you just use your very good eyes to distinguish that edge to avoid recurrence.
I think one other thing that is happening is, I'll go back here. When we inject indigo carmine stain solution, one should learn what is a normal round pit looks like and what it is not. If we can actually make that simple differentiation, this is a round pit, this is not a round pit, you cut until you get to the round pits, you will be able to completely eliminate all neoplastic tissue.
I think AI is definitely way of the future. We're somewhat early, I think, in the development of technology. It's much more advanced outside of the US, and we just have to be a little bit patient. It's going to be our friend, and it will help, but we're just not quite there yet.
So the other thing is an interesting question that you ask. When you cut, the AI doesn't want to leave your field. It will keep on blipping, giving that green box. The moment you have cut, it doesn't want you to get out of that field. It just keeps saying there is something there. So I don't know whether it's because of the cut or there is something left.
and rear microphone first.
Oh, Dr. Reicher, those are very nice pictures of that Sydney DMI classification. Around the same time, Dr. Bork also published his CERT classification, in which he somewhat controversially claimed that bleeding during the procedure was a risk factor for early recurrence, which has subsequently not been confirmed in other studies. What is your feeling about that as a risk factor?
I think my feeling is that bleeding during procedure is difficult, and what you brought up, having a lot of bleeding with cold EMR, probably obscures our field and presents a challenge. And I think there's been data, Dr. Maracoro, since then showing increased risk of recurrence in the setting of bleeding. I think less bleeding is always a good thing. We can sometimes not achieve it, but if we can, it's a good thing.
Yes, I think once you notice some bleeding, the submucosa gets stained red, and in that case, unless you develop an eye for identifying the submucosal connective tissue, it's like a mesh versus a polyp. Sometimes it is difficult.
Adrian, for the last question.
Yes, I'm sorry to focus on the thing that's been hashed many, many times. To go back to the edge of the polyp and the fact that you guys keep having to burn the edge. I remember a few years back, I watched Michael Burke take out a giant polyp, and the first cut was 50% normal and 50% polyp. So the first, the outside edge of the snare was way into normal. So there was almost a centimeter of normal around. And so my question is, I just feel like people are putting the first cut on the edge of the polyp should be well into absolutely normal tissue. We shouldn't be cutting very close to the edge of the polyp at all. I mean, so I feel like this idea that we have to burn the edge, that means we didn't remove enough. I mean, there should be we shouldn't be close, obviously, based on where it is, sometimes you can't do that, but there should be a huge, I watched them, and I went and I asked both presenters, why did you start? And they said, the first cut, the margin should be huge. We should not be close to the edge at all. So I don't think we should be needing to burn the edge. We should be cutting.
So I agree with you with the cut being a norm, including the normal margin. I think it is easier to do that with your first cut. And as you're going, it may come to an age where you may not be able to get there or whatever. So those things become a little bit difficult. And the second one is as you cut, keeping the lift of saline becomes also difficult because you have a large area that's oozing up. Yeah.
I think any resection, it could be, if you're not Dr. Raju and you're, where I live, and things can become challenging. If you have any tools, more tools the better. If any backups, if your thermal ablation is a backup, you're sometimes needing to use a cold snare is a backup. Your closure techniques, your evaluation of defect, the more is on your side, I always feel it's the better because it's always a challenge. But great point.
Thank you both.
Thank you.
Thank you so much.
Good to see you.